First, we had to restructure and recreate or create all the organizations that needed to provide it. So we literally had to recreate and restructure the contracting risk organization, which was central. We had to completely redo our employed physician group to change the way that they interact with each other and the hospitals and the other physicians. We had to completely restructure the hospital organization. We had to create the efficiencies. We had to pull in shared services. So we did a massive restructuring. Now, at that point when we started, it was just the 6 Caritas hospitals and 12,000 employees. By the end of this year, we're going to be somewhere between 19 and 20,000 employees and somewhere around 12 hospitals. So, you know, by the end of this year, we'll be the 2nd largest private employer and the 3rd largest employer in the state. So when you're bringing that kind of reorganization and change, it's not easy, and it's often not popular. But it had to be done. So we started with that. We had to figure out a way, this is 2.5 years ago, to incorporate private practice and community doctors, understanding that we had to make it appealable, appeal to most of them. I'm a doc. Let me tell you. You get 50 docs in a room and you ask for opinion, you're going to get 52 opinions. We were never going to win over everybody, and I knew that. But we had to get it from most. We had to figure out a way to unite everybody. And the simple thing that we had to provide was data. The one thing that everybody has in common in the physician world is that we're all trained to work on data. So, and we're all trained to challenge data. If you give them a study done in the United States, they say, well, that doesn't apply to Massachusetts. If you give them the Massachusetts stuff, well, that doesn't apply to, you know, Rentham. If you give them the Rentham, well, that doesn't apply to my practice. So you had to break it down at the core elements. And that's on the hospital side as well as the physician side. You had to break it down and be able to show how they, as hospitals, they, as physicians, they, as groups, actually compare to others and actually interact with others. And that's along all boundaries. That's in utilization. You know, why are you ordering an average of 1.2 MRIs per patient when everybody else orders 0.2? How come you never give your patients beta blockers when they have heart disease? You know, how come you as a hospital, how come you can never keep the rooms quiet when the hospital right down the road, similar layout, and the patient satisfaction is through the roof and yours is awful? You know, these are the challenges and the best practices that we tried to incorporate. You couldn't do that until we had a massive data platform. We had to create the hospital efficiency, so bringing out all of the individual components I described earlier. And then we had to tackle at the end stage, but really throughout, is utilization. So don't think of these as kind of step 1, steps 2, step 3. They're kind of all happening in overlapping fashion, but with different timelines. And some utilization we could tackle right away, like I said, which was duplication and things like that. Some of them we will be able to tackle within the time frame of our 7-year plan, comparative effectiveness research. Now, comparative effectiveness research is a term that everybody hears. What does that mean? Well, it's just what it sounds. We compare 2 things and see which one works better, and that's the one that we should buy. Seems logical. Not so logical when it comes to medicine because everybody's got their pitfalls and hang-ups about different devices. The problem with comparative effectiveness research is that it got into this rabbit hole of comparing one drug-eluting stent to another drug-eluting stent, when we really should be comparing medical management to drug-eluting stents. So it needed to be more epidemiologic, starting to head there with great help from people like Neha and others. So that's doable within the 7-year. Having protocols, getting physicians to agree on how to take care of a particular illness, that's tough. Because remember, medicine's a science, more of a science now. In the past, 20, 30 years ago, it was a pure art form. The doctors didn't have data. They were going by a lot of their personal experience. I mean, those were giants. Those doctors were making decisions on huge personal experience, what they heard, field, gestalt, and doing a great job. Medicine's changed somewhat. I mean, we have cold, hard data, and we need to begin applying that to more driven protocols. So that's all capturable within our 7-year time frame. And then there's things that we're not even going to try to address within the 7-year time frame because it has to come from society, and that's around utilization, end of life, all those issues. And as I've said, you know, that's not a decision for any provider to make. That's a decision for society to make and then providers to provide.